Hello, everyone, and welcome to today's conversation on total cardiac replacement in the context of cardiogenic shock. My name is Brock Fenzel, and on behalf of Syncardia, the Syncardia team, and today's presenter, I'd like to start by saying thank you to all of you for making the time to join us today. Your time's valuable, and we appreciate you spending it with us. I'd also like to thank our presenters, Dr. Rame, Dr. Moriguchi, and Dr. Liskowski, without whom this event wouldn't be possible. Each one of these gentlemen brings a wealth of experience to the table and more credentials than I could hope to name in the remainder of the time that we have. So I appreciate them all being here. Having seen the presentations develop over the last couple of weeks, I can tell you that each one of the presenters has put a tremendous amount of thought and energy into their presentations they're about to share with you. And I appreciate it. It's really an honor and a privilege to be able to work with such talented and passionate people. Program you're about to participate in was designed to be a little bit different than the traditional didactic presentation. We'd like to center it around real patients and the path that their disease and subsequent treatment took. We recognize that the TAH is somewhat of almost a paradoxical device and that its greatest benefit to a very specific group of patients whose disease run a wide gamut of etiologies and advanced heart failure. By hearing these experts discuss how they guided their patients through their journey, the discussions or the decisions that they made and the data that those decisions were based on, as well as their experience. We hope that you walk away with a more holistic understanding of the patients that most benefit from TAH. We designed this program with the advanced heart failure team in mind, specific advanced heart failure cardiologists, but nevertheless, we think this is going to be valuable to everyone. Quick note on logistics before I pass the floor to Dr. Rame, our moderator for today's event. We've gone ahead and muted everybody's line and asked that you remain on mute for the duration of the call just to avoid any potential audio distractions. That said, we do welcome your participation. Please just use the chat function. If you look at the bottom of the window, click chat and type away. Myself, the Syncardia team, and the moderators and participants will be watching the chat. For any questions or comments you may have, please understand if we don't address them right away. It's not that they're not important. It just may be that they're either going to come up in the presentation shortly, or we may be saving them for the end for discussion. With that, I'll turn it over to Dr. Rame and the panel. Dr. Rame.
So much, Brock. Such a pleasure to be here. It's great to reinvigorate discussion around advanced heart failure with this, during this pandemic and so forth. But we're here with Jamie Moriguchi from Cedars-Sinai and Mark Liskowski from the Montreal Heart Institute. And it's going to be my pleasure to go ahead and just see how this evolves with the case discussions and the preparations of incredible slides they've had put together. My task in the next 10 minutes is just to give kind of a, let's start all on the same page background with some of the nuances of cardiogenic shock in today's era. So if people can see my screen, I'll go ahead and put it into slide mode. Okay, so real briefly, first I just want to give a historical input because it's been about 75 years. It's amazing. And since I am in Philadelphia, just to be a little bit, I guess, parochial about where some of this started, a wonderful and humble man, Dr. John Gibbon, who was at Penn and also at Jefferson. He also was a resident at Mass General. This gentleman basically brought the era of cardiopulmonary bypass, really of open heart surgery, with the heart-lung machine that was developed in the early 1950s. And here's the first open heart surgery, and it's May 1953. And it was a young woman, an 18-year-old Philadelphia native, who had an ASD repair under full cardiopulmonary bypass. And I just want to make sure, just so we're all in this, we're all colleagues. Lots of people have called in. We're going to have a great session of discussion. But look what he writes to Dr. DeBakey. You see the little scribble here on the left. It says, "Dear Mike, a picture of the first successful open heart surgery, complete bypass of the heart and lungs, May 6, 1953. Best wishes, Jack." And that's John Gibbon. So real quickly, fast forward 75 years, and now we're basically, taking for granted how many times we do bypass the heart and lungs. I'm just showing some recent, this is actually up to 2016. So even the trend has continued on. And this is actual adult cardiac runs of VA ECMO. And veno arterial ECMO, as we know, is used in cardiogenic shock. But I just want to make sure we're all on the same page that what happened, most likely, people say, well, what happened? How come VA ECMO exploded? What happened with temporary support? I don't think any of us in the field think it's at all a mystery. I mean, number one, the technology improved for supporting adult patients and also having more success with longer VA ECMO runs. But the real reason is because we had, other than transplant, a real bridge with LVAD and total artificial heart technology kind of coming both at a similar time point to say, you can really bridge someone. So it's a bridge to bridge approach. But as you'll see from this talk we're going to give today with our colleagues, these overviews, we're going to think of all kinds of bridges, you know, including just obviously getting someone to the total heart, even with kind of Intermax 1 and 2 profile and seeing how that works. So you have an acute patient or acute on chronic patient with heart failure that survives cardiac arrest. Now what? So we have options here to basically provide circulatory support. We have options to provide ventricular unloading. You can augment coronary perfusion, obviously with the ability to support patients with the various devices. But what we're really doing is want to define a treatment strategy. Everybody deserves a treatment strategy as soon as possible. And we often can't do that in our field. You got to be patient and figure out, not only is this a candidate for advanced therapies, but even before that, is this guy biologically going to survive whatever you plan on doing with him or her? And I think that's the important part, is this rational pathway. And you'll see, I'll put a slide of this at the end, at the very end, when we finish, just so we're all on the same page and we're humbled by this, which is, it doesn't really matter currently, honestly, what strategy has been taken in cardiogenic shock. It's kind of sad. I mean, we do save lives, but if you look at data in aggregate, if you look at going back to basically, you know, era from the SHOCK 1-2 trial, now fast forward with some of the more sicker patients from the IMPRESS trial with the Impella 3.5 in a very sick, all of them were intubated population. Or you see Dr. Biswajit Kaur's data from Houston. Look, it's 50%. The mortality with cardiogenic shock hovers around 50. And there is something that we have done over the last several years to make it more standardized, more appropriate to jump into mechanical support. But let's just be very frank, we're not changing. There's no inflection point here. We're not changing survival yet. Importantly, if we just look at shock, and again, this is a pressure volume loop, but if we look at the paradigm of shock, when you have an acute insult that drops your stroke volume, and suddenly you begin to literally charge the patient with adrenaline, of course, we have all the hemodynamic indices that all of us know about. But what we have to be cognizant of is go all the way down to the bottom. Look at the associated, basically, clinical phenomenon. Long hospitalizations, heart failure, and mortality. Even if you're new to heart failure, you will have some heart failure after shock. We all know that. And I think that's what we have to kind of think about here more as we get to have more gray hair, like a lot of us, even if you're new in the field, is how am I going to think about this patient beyond this month? A lot of us can get someone home, but how are they going to do in 6 months, 2 years, 5 years? So bring in the shock teams, right? The shock teams now are defining all these algorithms. This is one that was developed while I was at Penn, most of the last 3 years. Now that I'm at Jefferson, we have a similar pathway for acute and non-acute MI. All these teams across the country, I know Jamie has a team. I know the Montreal Heart Institute probably is developing or has already developed it years ago. All these teams are coming to grips with what are we going to do so our nurses and our fellows and our residents and all our attendings know that we're treating shock as an entity with timeliness and also with some kind of standardization. So this is why this field is going to grow big time, is because now we have shock units across the country that are trying to figure out what to do with these patients. So we have VA ECMO in many configurations. Importantly, what does VA ECMO do? This is an important, and I hope I'm not going through stuff that Mark or Jamie's going to go through. Guys, just nod or tell me no so I can stop here and go to the other slides. But basically, we know that it loads the heart. It does achieve great circulatory support, and we can, for the most part, provide good oxygen supply as well as perfusion. But the LV, you must be cognizant that unless you have a recovery track or a recovery pathway for that heart based on it being inflammatory or other entity that it's going to be like Takotsubo reversible, you're going to have to do more to get this heart out of trouble. So you have all these different strategies for venting. And here's just a quick illustration. Again, you're going to drop the right atrial pressure with VA ECMO, but you're going to probably increase, if not top off, the left ventricular and diastolic pressure and the left atrial pressure, as you can see there. So what happens to the energetics of the heart when you're under VA ECMO? This is just a quick slide showing that you do have, this is the pressure volume area. We highlight it there underneath. And then if you have VA ECMO, it actually increases. So that means that the myocardial oxygen consumption of the heart has to increase. It's the total potential energy the heart actually, expends, and it goes up. Now, you can unload the LV with Impella, and we have, for example, the Impella plus the VA ECMO circuit, and that has worked. But let's just be very frank. We still don't have randomized clinical trials, nor do we have data that this strategy is the best way to do things versus, say, for example, creating a pop-off valve in the intraatrial septum and so forth. Bottom line, here's just a nice figure that shows how congested you can be under ECMO support. Most of us know that you can't just say, oh, we're under ECMO, now let's see what happens. You have to tune, tailor, and keep optimizing patients. So why should you convert patients from VA ECMO to temporary or permanent MCS soon? First of all, we know you may have inadequate support, meaning your LV is not unloaded. So therefore you get LV distension, you get pulmonary injury, which by the way is a huge morbidity and mortality after that. And you have to be really cognizant of that. I mean, you're not mobilizing patients often on VA ECMO. And I think the most important reason, obviously you need time to determine what the next steps are for recovery, but let's just be frank, the most important reason is time is of the essence. This is just one slide, and I think Mark is gonna come up with, is gonna show others, but you have a sweet spot. And 7 days, 7 to 8 days, you need to start getting nervous for your patient by 7 to 8 days, what's gonna happen next. Shouldn't panic if there isn't a direct strategy, but I'll be honest, in my opinion, if you go beyond 7 days, 2 weeks, if you're stretching that much on VA ECMO, something is bound to happen. And this is beautifully shown in this graph. The early, obviously, mortality in the less than 48 hours, that was more of a moratorium. Those people did not wake up. And then you have this real sweet spot of, basically up to about 7 days. So someone's on VA ECMO, what next? It's important to realize that we basically have some tricks of the trade that we've learned all as colleagues. We know the RV cannot be fully assessed. You have to turn the ECMO circuit down. And even then, really, I've learned from a lot of surgical colleagues, you really have to almost turn it down to see what the RV is really gonna do below 0.5 liters. And you can't often do that in the ICU unless the nurses start yelling at you. So at the end of the day, you have to be cognizant of the limits of what you can do on VA ECMO in your assessment. But the other thing is, obviously, you try to, look for the best strategies for recovery, but myocardial recovery may not occur because of what we talked about as far as venting. So again, this is courtesy of David McGiffin. He is a wonderful colleague from the Alfred in Australia. He gave me these slides. Here's just a pathway that he takes. He looks to see, obviously, okay, you got someone who just had who's in cardiogenic shock after resuscitating him. What do you do next? You try to revascularize him, and you look at, obviously, revascularize them safely with percutaneous strategies, and you look for the different strategies to either recover or bridge to advanced therapies that may be either heart transplant ultimately or destination with LVAD. But in each of these strata, let's just be clear, we have palliate patients sometimes. Sometimes they don't make it. And that's why you got to choose well and choose timely. I think the one thing I'm going to take home from today's session, I want to hear from others, is you got to be timely. So here's again, in their own center, let's say you go down this pathway and you're basically at a point of needing tandem, bi-sided tandem support or central back support or VA ECMO. The transition in their center is within a week. And this is what David has done. So we know this from the Columbia experience. It's used across the world. The CentroMag can be used as a surgical technique to go ahead and have patients or mobile from VA ECMO. This is a bi-sided approach, but clearly it's important to think that there may be patients when you do not have certainty of what's going to happen recovery-wise. And what I mean by that is you really don't have faith that the substrate you're dealing with, because there's either ventricular arrhythmias, there's infiltrative cardiomyopathy, there is evidence of a long-standing and irreversible refractory cardiomyopathy, you're going to have to bite the bullet sometimes and say, we're going to go for cardiac replacement and a cardiac recovery. So finally, I'm just going to say, as far as recovery, we know that it's possible even under LVAD support, but this data that we are writing up that should be coming out in circulation soon from Restage clearly is in patients with non-ischemic cardiomyopathy, within 5 years of having heart failure. We excluded more than 5 years out of having heart failure. And these were patients less than 60. This is a select group. And yes, we were able to get these EFs up, and we had a good explantation rate, and we'll see what the long term is. But just to be really humble, we looked at our data at Penn as far as how we did with ECMO weaning. How long can these patients survive, and how well do they do? So we defined successful weaning as those patients who were actually more than 48 hours and were doing fine on ECMO and then needed to be trialed for weaning. And here's our data basically for these patients that were able to be successfully weaned. We had survival to discharge in 64%, overall 1-year survival again 54%. If you look at actually this group, and this is the group that actually went home. Yes, if you get home, you're likely to maybe be okay in the next year. But if you look at the overall group, comparing patients that went on to LVAD or heart transplant, we didn't have anybody in the VA ECMO here go on to TH at Penn, but we had LVAD or heart transplant. You do better with LVAD or heart transplant than if you look long-term at these patients that were actually able to be recovered. So in summary, again, we'll go back to this slide. 50% is what we see as the current it still hovers the mortality around 50%. And I just want to thank my colleagues here now that I'm working with, Todd Massey. We have a terrific shock team here with some colleagues, Dr. Al Rawas and Alec Vishnevsky and Priti. And I want to just, an intellectual debt to my colleagues and still a very good friend of mine, Christian Bermudez and Ali Banayosi. Thank you. I think now we're going to present cases. I think the first person that is coming to speak right now is Dr. Jaime Moriguchi, who is the head of MCS at Cedars-Sinai. And he's just a long-standing, wise, one of the wisest people in our field. And I say wise because he's like John Kobashigawa. We don't know their age, but they age well. But Jaime is an incredible colleague, and he's going to go through some cases followed by Dr. Liskowski. Thank you.
I need to, there you go. Thank you. Okay, can you see my screen, Eddie?
Yes.
And you can hear me okay, right? All right, good morning, everybody. I was asked to share one of our cases that we found quite fascinating. I hope you do too. And I really want to thank Syncardia for allowing me to present this case, and hopefully it'll stimulate some lively discussion toward the end. So this first, hold on a second. No, it's not working. There you go. Okay. So our first case involves a 22-year-old female from Lompoc, California. If you don't know where that is, about 120 miles north of Los Angeles. She's blood type O, 5'2" and 130 pounds. BSA is 1.52. She had excellent health, really, until the 3rd of April. This is back in 2018 now. Just keep yourself reminded about that. And she had her first pregnancy, and it had to be induced at term because of eclampsia. Prior to that, she had no medical or cardiac history. She actually did fairly well initially, but over the next 6 weeks, she gained approximately 25 pounds with diffuse edema, almost anasarca, nausea, vomiting, diarrhea, and orthopnea, and presented to an outside facility in Lompoc with a pressure of 65/40. They were able to place a Swan-Ganz catheter in her, and she had an RA pressure of 25, PA pressure of 35/24 with a mean of 28 and a wedge of 25. Her cardiac output and index were 2.1 and 1.4 respectively. Lactate was elevated at 7. She had a transaminitis, and her creatinine was 1.0, and she was quite oliguric and overloaded. If you calculate the CPO, cardiac power output, it was 0.23, which is very low, and a PA pulsatility index of 0.44, also very low. And she had escalating inotropes, and urgent call was made to Cedars, and we transferred her within 48 hours when a bed was available. She was on maximum dose epinephrine, levo-fed, vasopressin, and dopamine, as well as an IV Lasix drip. She remained hypotensive with central cyanosis, altered mental status, and actually had a seizure requiring intubation. And we'll discuss the severity of her shock, but it was pretty obvious. We performed an echocardiogram, which I'll show you in just a second, but it showed a low ejection fraction on the left side and moderate depression on the right side with 2+ MR and TR She also had a right lower lobe infiltrate, which turned out to be a pulmonary infarct and possible secondary pneumonia. And because of her mental status, she had a head CT scan, which was negative. Here's the echo. The parasternal view on the left demonstrates the dimension was 5.1 centimeters in diastole, but you can see that the ventricle was pretty diffusely and severely hypokinetic. The right ventricle was also involved, but not as severe. I'd say it's mild to moderately depressed. And obviously she was in a lot of trouble. So the first thing we did, of course, was have to decide what to do about her. She's critically ill. Obviously, this is a decision point, and the different options include continued inotropic support, which was already on maximal therapy, consider temporary MCS, balloon pump, Impella, CMAG, VECMO. These all were things that we thought about versus a durable MCS or LVAD versus bilateral HVAD or even a TH. Go straight to transplant when we had not worked up for that, or withdrawal comfort measures. Now, this is a 22-year-old who just had a baby, and obviously the last wasn't even in our consideration. We elected to place a 5.0 Impella through her right axilla, and initially there was some flow improvement. We did not have a swan because of her pulmonary infarct, and but she didn't do too well. That was on the 24th of May. And basically within 24 hours, we had to place a Protect Dual, which is a catheter that is dual lumen, through the right internal jugular vein and place a tandem. So we had both right and left percutaneous ventricular support. And she finally turned around hemodynamically with that, with better urine output. We were able to wean off her drips. And she was, by a week later, she was actually sitting up in bed. This procedure we decided to name Tandela, which is an Impella on the left side, tandem RVAD on the right side, kind of like Cinderella, I guess. And basically she looked really good, was ambulating the unit, but she could not leave the unit, obviously. Over the next month, we actually spent getting her better nutritionally and ambulating the hall, which will be an important point as we discuss later. And unfortunately, she was found to be quite sensitized. Her PRAs were above 85%, class 1 and similarly class 2. So she received Rituxan and IVIG. And during that time, we optimized her status in hopes of doing a transplant. Now remember, she had a presumed postpartum or possibly viral cardiomyopathy. So we had hoped that she would recover. So we had placed the percutaneous devices to give her time for ventricles to recover. Unfortunately, by July, which was nearly, well, that was almost a month and a half, neither ventricle improved by echo, and she failed weaning on several occasions. Unfortunately, the Impella pressure, purge pressure started to increase, and subsequently the current increased. And on day 43 of biventricular support, percutaneous support, her Impella acutely failed, leading to a cardiac arrest. Fortunately, our surgeon was nearby and at the bedside right after CPR placed peripheral VA ECMO, which saved her hemodynamically. The patient was then taken to the operating room for Impella removal, which had a big clot on it, and she was felt to be Intimax 1 TCS at that point. She was neurologically intact, and thank God she was young. Her liver and kidney remained stable. She was relatively small with a BSA of 1.5. We considered a total artificial heart, but with a CT scan showing 8 centimeters transverse diameter at the T10, we didn't think 70 cc could fit, and she was unfortunately also medicated, so they don't normally approve for total artificial hearts, but we kept trying, and we had to decide what to do for her, whether we should exchange for a new Tandela, put bilateral CMAGs, which requires sternotomy, go straight to transplant, or consider a TH if we can get approval. And miraculously, of course, on the 12th of July, Medi-Cal approved after many telephone calls to the regional field center in Sacramento, and we implanted a 50 cc TH in her. And she was found to have a lupus anticoagulant, factor V Leiden mutation, but she was covered with heparin and did not have any major thrombotic or embolic episodes. This is the patient on July 24th, so this is several weeks after the TH. and she was sent to the floor and starting to ambulate and again improving her nutritional status and strength. All her drips were weaned off, and we felt ready to go to transplant. And again, we had to decide, we listed her status 1A, but she had already been in the hospital for over 2 months, and we had to decide whether to let her go home for psychological reasons versus keep her in the hospital. At that time, we were still in the old system of UNOS prioritization. So if they went home, even with the TH, they would be 1B instead of 1A. And we thought the better part of that was just keep her in the hospital because she lived all the way in Lompoc. So on the 20th of August, a suitable donor was identified for her. And this was hospital day 88 and post TH day 38. And the surgery was quite difficult and, as you would expect, quite bloody, and we left her chest open for a day. But she then stabilized out, and we had done some special preparation when we put the TH in to make this transplant a lot easier, which we can talk about later. But she got the TH and was discharged home within 10 days. And I just called her phone, and she and the baby about a week or two ago looked great. And this is a picture of them a couple months ago. So this is the case that we presented. We thought it was an amazing case of someone who was extremely sick. And these are the different issues that came up. It was a case of severe cardiogenic shock with potentially reversible etiology and a recent PE. It involved management of biventricular failure using a temporary MCS device, namely a Tandela in a very small patient, BSA of 1.5 and small LV. And the significance, which Dr. Rame referred to earlier, was that we use VA ECMO and how to manage that as far as timing and exit and venting strategies. And then, of course, the successful use of the 50 cc TH, which, as you know, is now commercially available and FDA approved in a highly sensitized individual. And the most important thing is that there was stepwise management, and everything had to go perfectly well for us to achieve a successful transplant outcome. But it did happen, and we're extremely thrilled about the results, and that's why I'd like to share that patient with you. There's several of the key takeaway points before we open up the discussion is that the patient had cardiogenic shock, obviously, but cardiogenic shock, like everything else, is a real spectrum of diseases from, somebody who's hypotensive and on a dopamine drip versus someone as sick as she was with end organ involvement, lactate going high, right heart cath demonstrating a very poor CPO and PAPI. And if you have to stage her for risk stratification, she would definitely be stage D in the SCAI nomenclature and Intamax profile 1 TCS. So she was sick of 6, and her survival expected less than 40%. And certainly if we didn't intervene, it would have been 0%. We also stressed the importance of temporary MCS, which in this case was necessary because we wanted to see if her heart would recover. She had just presented with several weeks of this acute decompensation, and it's possible that some of these patients would recover. So we used a temporary device instead of a TH, of course, to start off. And then you have to consider like the duration of support and how long these devices will actually work before you run into trouble, and whether or not she's a transplant candidate. It also buys you time to determine whether or not she's a candidate or not. And then, of course, you must know all the associated complications related to these devices, including hemolysis, infection, and stroke. Then, of course, we talked a little bit earlier about VA ECMO. Once it goes in, it can save you from, cardiac arrest. And you can do it while they're doing CPR. So it does hemodynamically rescue the patient, but then you have to develop exit strategies because within 7 to 10 days, the complications associated with that are quite high. Do you go straight to transplant from VA ECMO? You need to know what your center's results and success rate is, or bridge to bridge like the TH. And of course, when you use a durable device, you have to decide whether LVAD versus TH is indicated. Usually patients with NMX1 profile that's sick do not do well with the LVADs alone, and or you have to get them into a better state before you can use it. And often this would be a perfect role for a TH. That's basically it.
Fantastic, Jaime, that's amazing. Amazing case. Amazing the duration of support, right? For the lady in terms of you guys were patient to look for recovery. I think you told us about day 40, was it day 45, 46 when she had the event with her no longer flowing on the Impella?
Yeah, the Impella was in for 46 days of support. And, our longest is, I think, 50 days. But usually beyond 2 to 3 weeks, we start watching for evidence of failure. And the purge pressure is suggestive, but when the current goes up, you're in trouble and you need to change it. We were about to change it when she arrested.
We have one question from Claudio Bravo, but I just want to ask regarding that event, did you have any hints prior to that event where she arrested because of the failure, the support dropout? Did you have any hints that she could do that, as far as anything that led to you thinking she could have some thrombotic proclivity or anything prior to that?
At that time, we didn't know she was somewhat hypercoagulable. At least the studies for that had not returned. But
Okay.
once our purge pressure starts going up, we have a concern that there's a clot in there or there's something going to happen to the device. And then at that point, when the current goes up, we're 90% sure something's going to happen next 48 hours. So not always, but we're sure. But everybody's a little concerned about taking her to the OR. She was so sick. And we could never wean off either the LVAD or the RVAD for that matter. So, unfortunately, we waited, probably the wrong move because she arrested. And luckily, somebody was there and put a peripheral ECMO, and she did well. And the device had a big clot on it. So that luckily didn't go, to the brain.
There's two questions, so we have actually several coming in. So Claudio Bravo, Claudio asked, what do you think about BiVAD with either HeartMate 3 or HVAD versus TH? Said probably this patient is too small for HeartMate 3, but how about HVAD, BiVADs? I'm just gonna make one comment, Jamie, that is, the fact that she had thrombosis, thrombotic proclivity, I think that already for a lot of us, we've been able to support patients on bi-sided HVADs. The problem is the RVADs, even when in the pulsatile area, do clot. And I wonder how the durability in some of these patients who have thrombosis would be. And then there's the issue, of course, of how surgeons feel about, that kind of configuration. What are your thoughts on that?
So we've done 3 bilateral HVADs. Obviously, it was not FDA approved for the right side. 2 of them did well, but because we transplanted them, well, one of them did well because we transplanted them pretty quickly. The other ones who went home, one of them had a pretty big event about a year or 2 out, and the other one also had a stroke. So I'm not a real big fan of bilateral HVADs, and I don't think that's the right thing for this lady. She was very tiny. Centromag bilateral would have been the only other option I would have considered. But again, you still leave in the ventricles, which are not moving, and a great source for clots. And then you have other issues involved with infection. So you have to still crack her chest. If I'm going to do that, and I can get a THN, especially at 50 cc in this small lady, that's what I would have done every time. And that's the only thing that's going to save this lady.
Great questions are also coming in now, Jamie and Mark. You can weigh in here. There's a question from Dr. Brode. Would it have been beneficial to start with the total artificial heart rather than biventricular support prior to ECMO? In other words, that whole period of biventricular support. That's a great question. And then we have another question. Just I'll follow up real quick. The second question is from a participant that asks, was she already a transplant candidate at the time of the TH? Did you have to cross any antibodies or use, like John and you guys sometimes use eculizumab to get her to transplant quickly?
Oh, those are excellent questions, and it crossed her mind. But at the same time, remember, she was not in Medicaid patients, Medi-Cal patients in California. They're covered, and you have to get approval for that because Medi-Cal does not cover THs. So that's one problem. And spent almost a month calling Sacramento frequently to talk to them, and finally got them to approve it on the 12th of July. The second thing was, when we first put the bilateral percutaneous VADs in when she was real sick, we wanted to buy time. One is to see if she's a candidate for transplant. 2 is when we found out the antibodies, we needed to treat her. So we needed a month for that. And so, and then we also, because it's a recoverable etiology, wanted to see if the heart was going to come back. So that's why the percutaneous VADs seem to be the best choice for her. And, unfortunately, when you use those devices, you have to know that after about 3 to 4 weeks, the risk of failure can occur. So that's why you got to know your devices. And we were concerned. Luckily, we got away with ECMO as a bridge to transplant. We don't like to go directly from ECMO to transplant, which is another option we could have done because our survival is about 50 or 60%. But the ones that do well is actually a young person like this. The problem is because the antibodies, we thought we are going to have to wait a lot longer. So we put the TH in.
Yeah. That's a great case. For the sake of time, I think also Mark is going to be able to present maybe two cases of maybe more of a different timing as far as the TH. Jamie, you have another case as well, or that's
No, that's it.
That's the only one. Okay, Mark, go ahead. Thanks, Jamie.
Thank you.
Okay, thanks a lot. Everyone, that was a great case. I think what we're noticing is everybody has a different type of range of cases, and every case seems to be different. And I think it's tough to rely on data because there's not much data out there, but I think we have to rely on your local reality. You know, what are your transplant stats? What's your surgical experience? And you have to go a lot with that. So, so I'm a cardiologist in advanced heart failure and an ICU doc at the Montreal Heart Institute. This is our new center that we're building right now. They'll have 60 beds of cardiac critical care nature, hopefully to expand our progress. So, you know, there's a case of refractory shock that I'll talk about here. And obviously there's a lot of patients that have limitations to referral and or transplantation, either acutely or sort of medium term. So you're kind of stuck with maybe some patients with Intermax 1 and 2 that need acute support. And then once you get to that and you see who survived, then you have to decide what's your exit strategy if they're not potentially transplantable in the short or medium term. So as we mentioned before, and I'll show a couple of articles as well that sort of talk about this window of opportunity sort of in the 4 to 10 day range if you're on temporary percutaneous support or ECMO. And then all the benefits to go with being able to have a good hemodynamic support where you can clearly reduce the catecholamines and vasopressor use that are obviously have direct side effects and actually potentially contribute to worse outcomes. You can mobilize patients early if they do have implantable devices and obviously give a chance to bridge the transplant in otherwise acutely untransplantable patients. So cardiogenic shock obviously have a huge complication rate up front from the fact that they're just in circulatory shock, and you have to be able to reduce that component by using either inotropes and or temporary support. But then you have this whole problem of, systemic inflammatory response syndrome, potentially sepsis that adds itself onto it. The longer you're supporting your patient with percutaneous temporary support. So I think every patient's a bit different and every patient will have a different window of opportunity. And I think that's the importance of your shock team to have an established plan up front and be able to, within just a few days or the following day, change plans if you see an opportunity or a closure of an opportunity that may no longer be there. Typically from the data out there, we assume about sort of 6 to 8% complication rate on temporary support, about 6% infection rate per day. So I think, up front, you got to see if the patient gets better. And later on, you have to make sure that he doesn't exclude himself for any secondary plans because they develop more complications. So I have 4 cases, and it seems like the last 10 total artificial hearts we did, seems like every case was a bit different. Here are 4 different ones that we that went through all successfully. So a case of a lady with incessant VT, a patient with a huge post-infarct VSD, patient with acute humeral ejection, and already a transplant patient for a couple of years. It's been progressively getting worse, and all of a sudden she really became unstable. A patient with severe biventricular non-ischemic cardiomyopathy in a younger man. And the strategy initially for a lot of these patients, when we look at them with our heart team, is to see sort of what's the diagnosis, what's your acute support needed upfront to be able to save this person. We use often the SAVE score before putting in ECMO to see if they're going to survive, even if we do put an ECMO device or other type of temporary support device in to see if it's worth even going ahead. So case 1 here, we had a patient with incessant VT after a huge anterior MI. We tried an ablation that didn't work, but clearly she was so unstable, she ended up on ECMO. And this was sort of in the context of someone who we had to decide quickly what is her transplant candidacy. She was LVAD ineligible because of recurrent VT, 180 pounds. We found her to be quite highly sensitized from prior childbirth. So we knew, given her local stats, that she's not immediately transplantable. So we didn't want to keep her on ECMO at this point for any prolonged amount of period, because obviously immobility, the risk of complications, and so on. Second case, patient as well who was on ECMO after a huge VSD formed post-infarct. It was deemed non-repairable because of the size. It was really from apex back to the base of the heart from a huge anterior MI. He was on ECMO as a bridge to bridge the decision to see if he was able to recover from his shock. He was at this point a big guy, 230 pounds, obviously blood group O to make our life easy. He had multi-organ failure up front that actually was able to improve quite substantially after 10 days of support. And then we're like, okay, fine, we can lift him for transplant, but how long is this guy gonna wait? And given our local stats, we had to really ask ourselves a question, what is our mean transplant time for a person like this? And even status 4, which is sort of equivalent, I think, your status 1A, it might still take a few weeks. So we weren't necessarily going to keep him at this point. Our group tends not to do upper extremity biventricular support, percutaneous biventricular support. I think we tend to go directly more towards TAH because we have a lot of experience with that. But again, it points to these two last cases where you have someone on ECMO support and you have to decide, okay, what's your plan B? How do you get them to transplant if they survive acute hemodynamic stabilization? The other approach we have with a couple of patients is that they're not on ECMO, and maybe that's not necessarily the thing they need at this point. We had a lady who was transplanted a few years ago. She pretty bad course of events. She ended up with PTLD and with chemo, complications from that, bowel resection, ended up losing her kidneys from severe cardiorenal syndrome, from progressive restrictive cardiomyopathy from a chronic humeral, and topped off with a sort of acute humeral process. And at this point, she had severe biventricular dysfunction, refractory cardiorenal syndrome. She was being dialyzed on CVH at that point from low cardiac output, restrictive physiology type hemodynamics. She had an elevated PRA, and we did put her on a bortezomib plasmapheresis desensitization protocol. And at this point for her, she was awake, sitting in her chair, getting dialyzed, talking to us, not intubated. And we clearly knew that, what was our plan to get her to transplant? Because we deemed she was retransplantable. She was 42 years old, motivated, had a good psychosocial environment to sort of get her through this. And she clearly wasn't an LVAD or an ECMO option at this point, because we wanted to sort of get her through the best bridge to transplant decision. Then we have a case number 4, which is the same thing. A patient who's not on ECMO or PVAD presents with severe biventricular dysfunction. Ejection fraction is 5 to 10% in a 36-year-old guy. A huge atria, most likely sort of a process of already on biopsy, sort of a more sort of a chronic, acute on chronic decompensation, so something that's not going to recover. It wasn't like a myocarditis or otherwise. Clearly Intermax 2 at this point in the ICU and escalating doses of inotropes, obviously limited by non-sustained VT. Vasopressor doses were increasing, worsening cardiorenal syndrome. So our group sort of decided, okay, so what's our exit plan? Does he need acute hemodynamic support? I think he was getting worse, and I think we had to decide within the next 24 hours what to do with this guy. And then we looked at, is this guy transplantable in the short term? Big guy, blood group O, PRA negative, but given our local availability of big donor hearts, we've had a couple of patients, they waited up to 6 months to get an over 250-pound donor heart, especially blood group O. And he wasn't an LVAD option because his RV was completely shot. So we had to make decisions to where to go with this person. So we have a lot of these patients that come up with significant barriers to transplantation. If they are deemed to be survivors from their acute process, we have size and weight constraints. We have blood group constraints if they're group O, sensitization, instability of worsening organ function. So they are getting worse either very quickly or they're just not great with multi-organ dysfunction that hopefully is going to recover. That allows some more options. If they're not eligible as a bridge to transplant with an LVAD because the RV is no good, or if there's another process like recurrent VT or huge VSD. And then patients obviously who are deemed therefore Intermax 1 or 2 and not deemed as a bridge to transplant, a bridge to bridge candidate with an LVAD. So if we look at the data, and I think there's a lot of data saying obviously earlier is better, although you have to triage the patients who will not survive. So a lot of the graphs and the data do suggest that most of your deaths are typically upfront when you do take a critically cardiogenic shock patient and you put them on ECMO or some other peripheral support. A lot of the patients will die upfront. So I think that's an unfortunate triage that necessarily happens from patients who end up with either big strokes, neurological process after cardiac arrest, or multi-organ dysfunction. So the people that would die no matter what pass away within the first 4 to 5 days. And then if you sort of look at the potential outcomes afterwards, so we know that there's a high mortality upfront, and this is a curve, sort of a probability of survival over the course of the first few weeks on ECMO, and we try to extrapolate, what is the potential survival of a patient over the course of this process. So upfront, there's a high mortality just because we're probably too late, there's a complication, or he goes into refractory multi-organ failure, and he's going to die no matter what we do. Then you have the patients that start to get complications of being in the ICU with multiple inotropes, vasopressors, percutaneous support. They're intubated, they get septic, they get blood clots and have strokes. So obviously, if you wait too long as well on percutaneous support, you start to end up with a lot more complications. So there's a pretty narrow, although it depends on who your patient is, window of opportunity. And I think that clearly starts as early as day 3 to 4 or 5, where you can start to see who are the survivors who are starting to turn around, what patients are starting to urinate or renal function starts to improve, those who were not infected yet, and those who gives you at least 3 to 4 days to decide whether they're transplant candidates. So, if you look at infection risk over time, any person in the intensive care unit, which is either bedbound or intubated with multiple lines, to be infection-free, that probability goes down quite substantially over the course of just the number of days. So usually about a 6% infection rate per day on ECMO intubated. So, you can't wait too long because then you'll get a huge pneumonia and septic, and then you kind of miss a window of opportunity. And we know as well from a lot of the data out there that a large part of what we're doing to patients with high-dose catecholamines is potentially worsening their outcome. I think we're compromising perfusion to vital organs, especially the gut. And if we know that we lose the gut, then obviously the patient goes into refractory distributive septic shock, and the patient goes to multi-organ failure. So the inotropes we use to keep them afloat are clearly bad. And I think that a lot of the data suggests that if you can wean off the inotropes as much as possible with full adequate support, I think that's your best option to allow the patient not to get all those complications. Because we know that vasopressors can reduce organ perfusion, they increase the risk of arrhythmias, they deplete ATP and whatever to myocardial contractility, so your LV function actually gets worse. You have all the catabolic effects of catecholamines, increase the risk of infections, and otherwise you have immunomodulatory effects. So bottom line, just to keep someone intermax 3 or 2 by slamming him with inotropes and vasopressors is clearly not a good option. And then once you have the patient on some kind of percutaneous temporary support, let's say your center is not comfortable or experienced enough to put upper extremity percutaneous unilateral biventricular support. They're on femoral support in a patient who could not be extubated for whatever reason. Then obviously you have all the potential harms of prolonged immobilization, all the cardiovascular, respiratory, neuromuscular, and other risks of being prolonged in a sedation intubated process. And obviously the burden of clinical illness as well will have its impact on the patient. So you end up with a lot worse transplant candidate just after a few days to a couple of weeks than if you're able to get the patient up and running and moving fairly early. So a lot of our patients typically end up like this. They get VV ECMO, which is our quickest way to get them on full cardiopulmonary support, but obviously they're highly instrumented and it's tough to mobilize and wake up these patients, and obviously they're going to be bedbound. And in the long run, you get patients that are chronically critically ill, that are myopathic, that sometimes need tracheostomies, tube feeding. And this is not necessarily the patient you want to transplant up front, right? Because he's going to have a long road ahead with a high risk of complications perioperatively of his transplant, if you even assume he's transplantable at this time. And then after that, once you transplant him, then it's a long road down after that. And he might get other secondary complications like pneumonias and bed sores and other things that you try to avoid. And in general, the quality of life of these patients is pretty miserable, although it could take up to a year or so for them to actually end up out of the hospital. Versus if we take a fairly upfront, quick approach to more durable support, and as I was mentioning earlier, in all our patients that clearly were transplant candidates, but whom an LVAD was not their option for durable support, then we're pretty quick on the draw to go with our heart team to decide for a total artificial heart. To be able to exactly like this person here, he's one of the patients with severe biventricular dysfunction who got a total artificial heart up front. Within 3 days, he was already extubated and moving. And this could have been a patient who could have stayed on ECMO for a week or 2 or 3 waiting for a heart transplant. So clearly we got a better outcome, and he got transplanted successfully and is out of the hospital within 2 weeks. So, make sure you evaluate your exit strategy for refractory cardiogenic shock patients, especially the INTERMAX 1, 2, 3s. Have an exit plan for some kind of durable support, or even palliative care if you decide he's transplant candidate or not. If the patient is on ECMO, the TH exit strategy implant might sort of become a bit more concrete and then feasible as of day 4. So all the patients that were going to die, no matter what you do, will typically pass away within those first 3-4 days. And then you have this window of opportunity before they start to get ICU complications, sort of day 4 to 10, as all our other panelists were mentioning earlier. Upfront TAH, we do that from time to time as well in patients that I mentioned earlier as well that are deemed transplant candidates. If you have enough time to assess that they are candidates at that point fairly quickly, but they're clearly not LVAD candidates, or there's no other bridge where you try to avoid an ECMO as a bridge to transplant, then we go for upfront TAH with fairly good results. And obviously if the patient can literally walk into the OR, then he's going to walk out of the OR with his TAH and have a pretty good outcome. If you can get them off the catecholamines fairly quickly, and all the benefits of early mobilization of the TH allows you to have a much better transplant candidate, shorten hospitalization, length of stay, improve outcomes. And using the strategy, just in our last 10 TAHs, we've had an 80% success rate to bridge the transplant and discharge home. So we've kind of been pretty aggressive, thanks to one of our surgeons who's very who enjoys putting in the TH as it's a great device, and you've obviously seen the benefits from that. So, but it takes this person in the background to always hammer in the fact, what about TH? Is this a time to do it? And I think that's the most important part of your heart team, is to also have this in the back of your mind, where TH is a valuable option to get patients out of temporary support and get into transplant in a much better condition. So I'll end here, and I will ask Dr. Rame to field any questions.
Dr. Liskowski, Mark, that was excellent. And especially, I thought, giving the whole body perspective, we all focus on the heart, but then there's the issue of, skeletal muscle. And just like you said, so catecholamine support, and I agree with you, I think it depletes, muscle mass, but it also, we know it burns fat like crazy. I mean, you go back and see somebody after a month they've been in the hospital on catecholamines, and you can't recognize them sometimes because they've been so fat depleted, and they probably remain low output, some of them. So yeah, I think one question I have, we're waiting for some other questions from the audience. One question I have for you is, looking at the patient with the VSD, that had an ischemic VSD that presented, just briefly, did you end up laying out a strategy of when you'd go to TH up front, or were you considering, I couldn't see if you were considering heart transplant after stabilizing initially on some peripheral platform?
So the patient came after a huge infarct that was revascularized fairly late, unfortunately. He was transferred from a peripheral center. And we have one of our surgeons here who's sort of our local champ in closing the VSDs. Obviously, the first thing they tell us is, call us in 2 weeks, because they want the tissues to sort of harden a little bit and become a little bit less mushy, so you can close it a lot better. But right up front, just given the size of the VSD and the instability of this patient, in spite of a balloon pump, this is not a patient that we try to put an Impella in, because the VSD was so big. I think quite easily we could have already had sort of right to left shunting. An ECMO obviously was the way we sort of did acutely for this patient. But, we decided not to put this guy in ECMO for 2 or 3 weeks, waiting for him to potentially get complications. So it was really the surgeons that told us, listen, this is really not something that can be closed easily. I think you really need an exit strategy. And we did have enough time to assess him as a good transplant candidate. So we preferred to put in TH as opposed to waiting 2 weeks on ECMO, or deciding to close it with a high risk or just bad surgical result.
That was such clean decision making, because also, and a lot of us, if even a balloon pump who you think, is going to minimally give you a right to left shunt, you could also, create the imbalance of the pulmonary and systemic vascular resistance, and you can get into trouble. So I think that decision was to move forward with a platform that could just get you out of trouble completely. We have Dr. Copeland on the line as well, and I'm just going to ask, because I remember visiting him years ago in Arizona. And again, he was formulating back then some guidelines for the kind of patients that you really want to just focus on to give them the best chance to get them out of failure and quickly. I don't know if he can maybe comment a little bit or give us his input on this, because I clearly believe VSD, the large ischemic VSD patients are definitely a substrate. The patients with refractory VT, as you had one as well. And then obviously, Jamie had a patient with, recent onset heart failure, but clearly, after weeks of waiting for recovery, there was not even a signal. So I'm just curious if Dr. Copel can give us some insight of how he sees the field now on that.
Yeah, I've goofed around here and somehow I've gotten out of the video of this. You can still hear me though, I guess. I think one of the things that has been brought home by both of these gentlemen that presented, gave great case reports, is that you can only wait so long in these patients once they go into cardiogenic shock. And you did that also, Eddie. I mean, your preamble to this was essentially the same thing. And I've always said that ECMO is a dying model or a dying process, and it's just a question of time. And I think you've all kind of mentioned that you can only wait 4 days or 10 days or not more than 10 days before things start going south so badly that you just don't have an opportunity. And it's just a question of what the disease process is and what the reversibility of that disease process is that determines whether you go ahead with a total heart or not. And one of the things that struck me about Jamie's presentation was, how do you know how long to wait on these patients that may have reversibility? I mean, obviously you're on some type of support, but you are you're stuck because if you wait too long, then you're not going to be able to do anything at all for the patient. So the question for Jamie is, what do you have any guidelines for that? I mean, do you try to wean, and then if you can't wean after a certain period of time, what is that period of time?
It kind of depends upon the etiology. For postpartum, I don't think anyone knows for sure, but usually if they're not coming back, or certainly if they, with her situation at 6 weeks, there was no recovery at all. And we tried to wean both the LVAD and the RVAD, percutaneous VADs, and no go, she crashed. So we were thinking about switching her to a TH, but we couldn't get approval. So we would have to go either to bilateral centromags or, which nobody wanted to do, because she looks so good with the device, the percutaneous devices. Then of course that little increase in approach pressure and then followed by increase in current with Impella, we kind of knew we were in trouble. And maybe we waited a little too long because she arrested, but that's the way it is.
Yeah, well, I mean, I would agree with you. It's highly individual, and it goes with each patient is different. And but you always have to keep looking and asking that question. Is this heart really going to return, or is this a transplant candidate? In those reversible patients. I mean, the last thing you want to do is transplant somebody that doesn't need a transplant. And they'll always do better with their own heart if it returns to normal function. But so many of these patients that we see coming in with cardiogenic shock, they're not going to do it. And I don't think there's any magical way to figure it out. You just have to get in there and put your feet at the bedside every day and check out the patient and try to make a decision in that way.
Thanks, Jack. It's a really good point. I remember when coming down to visit you years ago, and I saw the patients you'd implanted, it was clear to me that there were some patients that, and back then we really didn't have we didn't have even an idea how VA ECMO could be stretched beyond a week. I mean, we used VA ECMO as just literally a means of seeing if someone's neurostatus got better. Nobody was doing any ambulatory ECMO or otherwise. I mean, central VA ECMO was different, but peripheral VA ECMO, which is often used as a means of just, sitting tight, not doing anything quote unquote invasive. But I definitely learned that back then, I think you have to make some hard decisions if someone is intermax, 3 going on to 2, but you still have the ability to, with some degree of either a pharmacologic degree of unloading, just to give that patient a reprieve for a day or two to plan the team. I think that's what I wanted to ask is, it would be neat to ask the question, how many patients came to TAH without ECMO, and how those patients were decided upon, with some kind of data behind it. Because I'm sure a good cardiac team, like Mark was alluding to, can make a decision within a couple of days that, hey, this is not going to work if we're going to keep this patient on ECMO for too long.
Yeah, well, in our day, we use very little ECMO. The typical use of ECMO would be taking somebody who had severe dilated 4-chamber cardiomyopathy, had a cardiac arrest, put him on ECMO, and go straight to the operating room, and or within hours. So we didn't wait very long. So every patient was in cardiogenic shock that got a total artificial heart, or any kind of a device for that matter, whether it was a BiVAD with external ventricles or an LVAD. They were all in cardiogenic shock, essentially, in those days, because we were afraid to use these devices in anybody else. And, very fortunately, the total artificial heart worked very well in most of those situations, and better, in fact, than LVAD or implantable or external LVADs. So, yeah, a short period of time, I think, is the main message.
Thanks, Jack. We have a question from Val Rakita. I don't know if Brock, do you want me to just summarize this question? I think, Val, if you want to clarify your question, then we have another question from Claudio Bravo. Val, you want to come on the line and clarify your question for, this is for both actually, and for the whole, for Dr. Copeland as well. Go ahead, Val.
Sure, thanks, Eddie. They're all great case presentations. It seems like the common theme, it's a lot of acute presentations, and the TH is being implanted, while they're still inpatient. And are all these patients formally considered transplant candidates at the time of TH implant, or is there some question to their candidacy and, it's being implanted without knowing completely if they're truly going to be a bridge to transplant? I know there's only an indication as of now for BTT patients.
Yeah, I can answer for Cedars. The majority of our patients who get implanted with a TH have to be run by the selection committee and accepted for transplant, just because, it's the right thing to do, but the insurance won't cover it if it's not. Now that it's available as DT, I'm not too sure how that factors into things, but in general, you have to do that evaluation before you put a TH in, otherwise it may be a bridge to nowhere.
Yeah, here in Canada, we don't have any, fortunately, any insurance or regulatory issues that really prevent us from putting it in. We just go to the storage room, take something off the shelf and put it in. But I think, we don't have the experience of sending patients home. And typically, if we did put a TH in, they will get transplanted within, worst case scenario, 3 to 4 months, typically in hospital. And again, we don't think it's probably the best option to send patients at this point in our experience locally with TH. So we'll typically, have the heart team quickly, within the first 48 hours, see if they're transplant candidates. The surgical team will see if there's anything they can do to either repair or allow the heart to recover. And our ICU team will sort of decide, are they improving on temporary support, and what is our window of opportunity? So we really have everybody working side by side, and we have a plan within 48 hours for most people in terms of, okay, these are options A, B, C. Let's see if he recovers, and what's our next step.
Hi, Francisco Rabia, just joining late.
Hey, Francisco.
Hi, Francisco.
Hello, guys. So, yeah, we just did a TAA 2 days ago as a bridge to candidacy, approved by the insurance company after we discussed it with them. So there is room to move when you discuss it with insurance companies. This was an Intermax 2 patient with a long history of drug abuse and rehabilitation that we wanted to make sure that he's fully recovered prior to going to transplant. So they gave us the approval like that. We have received several already bridged to candidacy. So it's possible.
And I want to just add a case that actually Francisco and Jack helped us with at Penn. You remember this case of a lady who was a CHOP patient who'd had a transplant 20 years ago, and this really, I think it was bad humeral, but also like just CAV that just didn't look bad on cath. I think she had really bad CAV, had a very horrible heart, stiff heart, and she was on VA ECMO, and unfortunately developed, she had a spinal infarct on VA ECMO. So this lady ended up recovering on a total artificial heart over 2.5, 3 years almost. She actually began to walk. We were going to send her to you, Jamie. Remember her very well. We would not transplant her because we wouldn't desensitize her at Penn, which is a shame. But we've had not great experience how to desensitize. We wanted experts like Cedars and others to do this. And this young woman, God, you know, the courage she had and everything. She had a good quality of life on the total heart. She really touched a lot of people, but she ultimately succumbed to sepsis, you know, short of trying to get her transplant. We were also looking at centers like in Florida, because, you know, centers where she could have family to go to. But yeah, she was almost 3 years, I believe, on the total heart.
Oh, she was young, right? Really young.
Very young. Yeah, it's good to be young. She was also unbelievably, I mean, the spinal infarct, I mean, she started walking towards the end with almost no assistance. It was just unbelievable to see that.
Wow.
Yeah, and she was a case that I think she was on ECMO for about at least 6 weeks.
She was Christian's patient. I wish he was on to discuss it.
Yeah.
Really tough case, but I mean, he gave her the best chance. And just to answer Val, we had not vetted her for transplant, even though we thought she could be a bridge to candidacy, because we would not desensitize her. She was very sensitized coming into, you know, when we were evaluating her on VA ECMO, very sensitized. Yeah.
Okay.
Sorry, there's one other question here, Francisco. Well, and then Jack, while we have you, we have Claudio asking 2 questions. In regards to the patient who had AMR, pre-heart transplantation, he asks, does the TH sensitize patients as much or as, depending on your opinion, as the LVAD does? And 2, is there any data that patients undergoing heart transplant off the TH do better than those bridged with ECMO? Excellent questions. Those are great questions. Jamie or Mark or Francisco or Jack, anyone else?
So I think there's some data showing clearly that after LVAD, people are more sensitized. Are the bodies actually really pathogenic, or is it just sort of non-specific antibodies because people are acutely inflammatory? A lot of these patients, if you sort of check how whether antibody titers are with C1q, more specific complement activating, or you recheck their PRAs a couple of weeks, a couple of months later, sometimes that changes quite a bit. So it's unclear exactly how pathogenic those antibodies are up front. For TH, I suspect it's about the same process. You know, you get a sternotomy, you get lots of blood products, you get foreign material put in. One of our patients had an LVAD recently, and exactly ended up going from like a 10% PRA to 100% PRA, and we're still retest her soon to sort of see if that goes down. We've had pretty good success going from TAH to transplant. I think we tried putting an LVAD into a patient with biventricular dysfunction just last week, and he ended up needing an RVAD. Then he lost his kidneys, and then he had to be sedated. And so it was just a total mess. And I think we regret not having gone to TH up front for this guy last week. Fortunately, he got transplanted 2 days ago, and he's doing fine. But you know, we lost the kidneys in the process, and we may not have lost him had we gone to TH with just one major surgery up front instead of serial procedures and, you know, shock and recovery and shock and recovery. So I think it's important to keep in mind, you know, what how the patient is doing, and not, you know, not escalate and de-escalate and escalate. So that's what our thoughts are.
Yeah, our patients who went electively to TH, no MCS before that, the overall survival or success to transplant is about 65-70% or so. If you get VA ECMO between, that survival goes down to about 48%. We did 25 patients via ECMO to TH, and about 12 of the 25 went to transplant successfully, but it definitely is less. And then if you look at the best part of it all, though, is once you have a patient who's on TH and stable and optimized, if they go to transplant, the 1-year survival after transplant, in our experience, has been 91%, which is almost like somebody coming off the street. So I'm not worried about the sensitization about the from the TH.
Yeah, let me add, that's a great question. On the, what I have found over the years is that the TH itself do not increases the antibodies. It is the blood products that they receive at the time of the implantation, especially platelets. And we have had several patients that the PRA will go up and come down. But we did find at Cedars, and you can correct me, Jamie, is for all the devices, the non-HLA goes up.
Yep.
And where we now are doing for any device patient that we're going to transplant, TAH or ELVA, if they have a PRA, we will check non-HLA antibodies. And if they have AT1R that is high, for example, or endothelial, we might consider plasmapheresis right at the time of the transplant. So we don't have a problem. That is what we have found. But the class 1 and class 2 HLA, I have not seen those just go up because of the TAH. It's when there is a lot of transfusion of blood product.
Yep.
I want to thank everybody. Brock, do we have 2 more minutes? There's one last question that is interesting. I'm sure there's going to get a lot of different viewpoints, but what is the time frame? I don't want to take up people's times here. There's another question by the participant here.
I sincerely appreciate everybody's time thus far. We can keep the webinar open as long as people want to discuss, but I understand if people need to drop off. I thank everyone for being here. So if we'd like to address that question, by all means, please.
Yeah, well, anyway, thanks everyone. If you have to come off, this has been great. Thanks, Jamie, Mark, and it's great to see Dr. Copeland and obviously Francisco. The question is actually if there's any change in the post-implant management now that there is no nasiritide available commercially. This is a very interesting question that Val asks because of, you know, some of the hiccups that some of us had with nasiritide. Interestingly, we try to learn from Dr. Copeland and others, Francisco, you as well, in which there was less nasiritide dependence across many centers, depending on the experience. Whoever wants to answer that, I'm not sure. I'm sure you can find nasiritide in Canada, right, Mark? Probably in one of the Canadian pharmacies.
Yes, I think it's generic. You can pick it up at the gas station, actually.
Well, you know, it's interesting because we have encountered that in the last several TAHs that we have done when we have no nasiritide available. And what we have done is a combination of either UF, ultrafiltration, or CRT to maintain the volume at a normal range and give enough time for the kidneys to recover. And we have done that intermittently in the last few patients without nasiritide, and we have recovered renal function. So you just maintain euvolemia and adequate electrolyte balance for those first few days, if necessary, with UF and CRT, and we've been able to get through it. And actually, that's the way we used to do it long before we were using nasiritide.
Thank you so much. I think that's going to be a great research question using a historical control of before and after nasiritide. Maybe
Yes.
There's no difference. Thanks, everyone. I appreciate everyone's time. Brock, I'll leave it up to you if you want to close, or the team.
The only thing left to say is thank you to everybody that was here. I sincerely appreciate you carving out the time. To our presenters, to Dr. Rame, Dr. Moriguchi, Dr. Laskowski. Thank you so much. This has been wonderful. For anybody who would like to share this after the fact, we will be putting up a recorded version of this. And again, I thank everybody for their time. Thank you.
Thank you very much.
Thank you. See you guys.
Thank you, doctors.
Bye-bye.
See you later.
Take care.